Good morning everybody. I am Dr. Nitin Joshi Professor in urology with teaching experience of 25 years working as consultant neurosurgeon in Panvel. We have got a patient who has got raised serum PSA in gray zone area of 4 to 10. His digital rectal examination normal, percent free PSA less than 15 and his prostate biopsy has come positive. Now the factors on which the patient who has got localized cancer prostate depends are: 1. Age of the patient, life expectancy, prostate cancer risk stratification, performance status, preference of the patient and the expectation of the patient in terms of quality of life after treatment. Now performance of the patient, that is when the patient is having cancer prostate, there has to be some scalar system on which the treating clinician can evaluate the patient, that is the impact of the disease on the patient as well as impact of the treatment in terms of radiotherapy, chemotherapy or surgery on the patient, in terms of his ability to carry out day-to-day activity, self-care as well as his work. And so it notes down the functioning of the patient in terms of his ability to take care of himself, second his physical activity, his day-to-day activity. Now at present various systems are available. The one which are accepted, that is the Eastern Cooperative Oncology Group, that is ECOG group, or Karnatske performance status. One which is easily practiced in the clinical practice is ECOG. It is asked in exam as well as in theory, and so we will discuss shortly. That is grade 0, where the patient who is totally active with respect to his physical activity, his day-to-day activity, his work as well as the ability to take care, which prior to his disease and after disease he is same, that is perfectly alright. While grade 1, where the patient is able to take care, is able to perform the work but is only sedentary work, is able to perform only light work and his strenuous activity regarding physical activity is restricted. Group 2, where patient is ambulatory, he is able to take care of himself but now not able to do even sedentary or light work. Grade 3, that is capable of taking care of himself only limited, and about 50% time he is restricted to bed or chair. While grade 4, he is totally disabled, that is he is bedridden, 100% he is restricted to bed or chair, so not able to take care of himself. And grade 5, that is dead. So these performance status also matters. So the age, life expectancy, performance status, then the risk stratification, preference of the patient and expectation of the quality of life after treatment. Now suppose if your patient who is having raised serum PSA in gray zone area, diagnosed to have cancer prostate, age more than 75 years, history of diabetes mellitus, myocardial infarction, what will you do? Now here you will tell the examiner that I would always see the factors which affect the patient who is in localized cancer, selection criteria. There are, because options which are available are watchful waiting, active surveillance, radical prostatectomy, radiotherapy. These are the common options which are available. Now I have to look into the matter, that is age of the patient, second performance status, third life expectancy less than 10 years or more than 10 years, then his risk stratification, and then I should counsel looking at that he is going to have life expectancy less than 10 with the comorbidity index of Charleston's, his age more than 75 years, his poor performance status because of comorbidities. Then I will ask the patient that look, it is a decision of the family, we should sit and discuss, but These are the factors which are against your aggressive treatment, and aggressive treatment in forms of radical prostatectomy or radiotherapy. One, age, so the life expectancy is going to be less than 10 years. Second, poor performance status, as well as the disease which is there is indolent, slow growing, likely to progress to cause the cancer related death. So the patient can go ahead with the watchful waiting. So now, what are the selection criteria for watchful waiting? That can be the question which will be asked. The criteria selection is age, that is elderly age group, more than 70. Second, that is performance status, which is poor performance status as per the EXHOD or Kornowski performance status. Then the life expectancy less than 10 by comorbidity index. Then the risk stratification, prostate cancer risk stratification, if it is indolent type of tumor, slow growing, and preference of the patient, that is family as well as physician. These are the criteria on which you select the option, whether watchful waiting, active surveillance, radical prostatectomy or radiotherapy. Now, what is the indolent tumor? When you say that you explain the patient that you are having indolent tumor, then the question will be asked by the exam, what do you mean by indolent tumor? Then indolent tumor, on the sonography, the tumor is less than 0.5 CT, it is organ confined, then serum PSA is less than 10. On histopathology, it is Gleason score ideally equal to or less than 6. If it is 7, it should be 3 plus 4, not 4 plus 3. This is because primary predominant pattern is 3, which has least or no potential for infiltration and invasion, so slow growing. In case of 4 plus 3, the Gleason score is 7, but 4 plus 3, it has got 4, which is predominant pattern. It has got potential for infiltration and invasion, and so it is an aggressive variety. So, and there is no bad histopathological pattern seen on the Gleason score is called indolent tumor. So if the patient is having indolent tumor, then also the patient of having the progression causing the cancer related is less, and so the patient can go ahead with the watchful waiting. Now, what is watchful waiting? It is a treatment option offered to the patient who is having a localized cancer prostate, in whom this particular locally aggressive treatment like radical prostatectomy or radiotherapy cannot be given because patient is unfit or unwilling. So here the intent of treatment is not curative. Here what is done, the patient is carefully watched for progression of disease locally or systematically, that is progress to metastasis. Since the patient has not been treated with local curative intent, that option is closed off forever. Since not given any treatment to primary, it will progress locally or systemically to produce mets. So when the patient becomes symptomatic because of progression of the disease locally or progression of a disease to the mets, that is common is bone, then symptomatic treatment is given with the palliative intent, particularly when the patient is having bone mets, palliative intent to prevent the painful merciful death. Commonest is androgen deprivation therapy. So the question will be asked, what is the philosophy behind the watchful waiting? The philosophy here is that patient is elderly, is having multiple comorbidities, life expectancy is less, poor performance status, and so the local aggressive treatment in form of radical prostatectomy or radiotherapy patient cannot tolerate or withstand. Treatment may harm rather than help. So double loser, and so just allow to progress, monitor closely to see whether the patient is progressing and give symptomatic treatment so that his quality of life is maintained. So the curative, it is not curative but just the palliative intent. Doctor, the question can be asked, doctor, you are saying that you are going to offer androgen deprivation therapy to the patient when he becomes symptomatic due to spread to bones or liver, commonest is bone. Why don't you offer the treatment immediately? Then the question is that with the androgen deprivation, the answer for that is that with androgen deprivation therapy, there are well-known complications like decreased bone mineral density, decreased muscle mass resulting into increased skeletal events, anemia, because of anemia and decreased muscle mass, weakness, fatigue, increased incidence of metabolic disorders like diabetes mellitus, dyslipidemia, increased cardiovascular events resulting to decreased life expectancy, hot flushes, and so all this will decrease cognitive function. So all this will result into decrease into quality of life deterioration. So these all complications should be, as far as possible, should be delayed. So this androgen deprivation should be started when really it is required. And second concept which is given is that if the androgen deprivation therapy is started early, there is a possibility of development of castrate resistant prostate cancer also early, which may progress to even androgen independent cancer. And so androgen deprivation therapy should be given even in patient who is in the watchful waiting group when it is really required, rather than giving immediately. Now the next question which can be asked is, how will you monitor the patient? The patient who is in watchful waiting, how will you monitor? Now normally the patient is asked to come for regular follow at 6 monthly interval by doing serum PSA and creatinine. He will be asked a detailed history and will be done clinical examination. What it will be asked for the progression of the disease locally and any metastasis. Locally, that is, if there is any deterioration of the loose in terms of progression of International Prostatic Symptom Score, any systemic spread, that is particularly bone, so any bony pain or swelling, and the clinical examination will be done for the any lump, because if there is progression, the disease may progress upwards to the bladder neck and involvement of the trigone, resulting into obstructive uropathy causing hydrouretronephrosis and hence palpable lump. Second, suprapubic region, whether palpable bladder. Per rectal examination, whether there is extension, and so the median sulcus if obliterated, whether there is mucosa over the rectum is free or it has obliterated, and palpable seminal vesicle, all indicates extension of the tumor. Ultrasonography is extension of clinical examination to show whether there is any increase in the size of the prostate. Second, increased post-void residue, and uroflowmetry to see whether the Qmax has deteriorated. Then the examiner will ask, what does it matter, doctor, if there is already patient is likely to progress? Why you are worried whether there is the prostate volume has increased, Qmax has decreased, or PSA has increased? What is the significance? Then you will say that all these factors, that is the factors that is increased age, increased prostate volume, increased serum PSA, increase in the International Prostatic Symptom Score, and fall in Qmax are the risk factors for acute urinary retention. Then the next question, you had evaluated the symptoms in terms of International Prostatic Symptom Score. What is this International Prostatic Symptom Score? You will say, sir, it is a scalar system to evaluate the severity of the LUTS, that is lower urinary tract symptoms, in which the symptoms are not just enumerated in terms of poor caliber or poor stream of urination, intermittency, straining, sense of incomplete evacuation, frequency, urgency, nocturia. But each symptom is evaluated in terms of the severity, how much it is bothering and affecting the quality of life, and how frequently it is occurring, and the score or the points are given depending upon the bother and the frequency, and then all these points are added to give a score, and this score runs from 0 to 35. So the patients are classified as mildly symptomatic if it is 0 to 7, 8 to 19 if it is moderate, that is moderately symptomatic, and if it is 20 to 35, then it is severely symptomatic. So the next question the examiner asks, you have evaluated the patient, there is presence of increase in the prostate volume, patient Qmax has decreased less than 12, PSA has increased, there is international prostatic symptom which has increased from mild to moderate to severe. You are expecting that he may go in acute retention of urine. So what you will do? You will say, sir, I would like to put the patient on the combination treatment of alpha blocker and 5-alpha reductase inhibitor. Then answer the question which will be asked, how it works. Then you will say that this patient is elderly patient, diagnosed case of cancer prostate, but in elderly patient there is many times there is association of BPH with cancer prostate and with the cancer prostate BPH. So this co-association, they are associated with each other, so there is high incidence, possibility, probability that there will be even presence of BPH. And in BPH there is static and dynamic component. Now in case of dynamic component, what is seen that because of aging, that is autonomic dysregulation, and the dynamic component is because of increased activity of sympathetic alpha-1 adrenoreceptor activity, that is autonomic dysregulation. Now these alpha-1 adrenoreceptors are predominantly seen in the bladder neck, urethra, that is the prostatic urethra, as well as the prostatic capsule. Because of this alpha-1 adrenoreceptor overactivity, the smooth muscle present in the bladder neck, prostatic urethra, and even the smooth muscle present in the prostatic capsule will contract. Because of contraction of the smooth muscle in the bladder neck and the prostatic urethra, there will be narrowing. And because of the contraction of the smooth muscle due to overactivity of alpha-1 adrenoreceptor, alpha-1A adrenoreceptor, will result into pushing of the prostatic tissue, that is benign as well as malignant tissue, towards prostatic urethra, causing further narrowing and hence further obstruction to the flow of urine. So alpha blocker may be partly helpful to block this selectively alpha-1 adrenoreceptors, alpha-1A adrenoreceptors, thereby causing the relaxation of the smooth muscle present in the bladder neck, prostatic urethra and the capsule. While the 5-alpha reductase inhibitor, now androgen has permissive role in BPH, while it has got a critical role in the pathogenesis as well as progression of cancer prostate. Now the testosterone, 95% source is from the testes and 5% is from the zona reticulosa of adrenal cortex. When the patient is in the watchful waiting, where the patient has not undergone orchidectomy, he has got the source, that is the testes as well as adrenal cortex. So the testosterone which is present, which is about 90 to 95% is bound form, 5% is active, which is free. This testosterone will pass passively along the concentration from the plasma across the cell membrane into the cell of the target organ, and that is prostate. In the prostate, there is androgen receptor present in the cytoplasm. This testosterone will combine with the androgen receptor that is ligand binding domain of the androgen receptor, and then there will be what is called dimerization and phosphorylation and translocation. During translocation, it will pass across the nuclear membrane. At the nuclear membrane, there is 5-alpha reductase enzyme type 1 and type 2 isoenzyme. This 5-alpha reductase is responsible for conversion of testosterone into dihydrotestosterone, which is about 8 to 13 times more potent than testosterone. If there is blockage of conversion, naturally there will be fall in the dihydrotestosterone, which is important because this dihydrotestosterone will go inside along with the androgen receptor, and then androgen receptor, which has got what is called DNA binding domain, will combine with the androgen response element to result into the coactivation of the nuclear receptor, resulting into the transcription. And this transcription is important because newly formed messenger RNA comes out to result into translation, that is synthesis of proteins which are required for the proliferation of the benign cells as a normal cells as well as cancer cells. If there is inhibition, the potent testosterone is not formed, but testosterone is formed. So there will be this testosterone which will be present. There will be just small reduction, but testosterone combined with the androgen receptor, it is not converted into potent form, but the testosterone which is combining with the androgen receptor will still go inside, and there will be some transcription, there will be some synthesis, and so there will be some proliferation of the benign as well as malignant cells, but there will be some shrinkage of the cells resulting to reduction of the volume of the prostate. So this may prevent the patient from the acute retention of urine, where the pathology is not known, but there is obstructive myogenic and neurogenic component. So now the next question will be asked. You have put on the patient on the combination treatment, but after 8 days patient comes with acute painful retention of urine. What will you do? Now you have already started. Now first important, you will see it is a painful tender. So naturally you have to relieve the obstruction. This is because more there will be distension, the more there will be ischemia to the wall of the bladder, infarction, and the contractility of the bladder will decrease, and so the immediate decompression is important. I will do the catheterization under strict aseptic precaution. I will collect the urine for routine microscopy. Particularly, I will do the bedside for the presence of infection, because that can be a precipitating event. So, urine routine for pus cells, bacteria, nitrite test. Pus cells may be present because of catheterization. Nitrite test and the leukocyte estrase test. If nitrite test is positive, presence of bacteria, I will send for culture. Now, then I will ask history whether there is any precipitating event which has resulted into progression into the acute retention of urine. That is, whether he has postponed the urination though he had an urge, whether he has taken excessive any soft drink or any alcohol or more water, or any cold pill which is sympathomimetic, which will stimulate alpha-1 adrenoreceptor, or anti-allergic drug like antihistaminic, or any anticholinergic drug for maybe for the psychiatric or the depression, which may be the precipitating event. But I will counsel the patient and patient's relative that most likely it is a progression of disease. It is, even if there is certain precipitating event, there is bladder outlet obstruction because the disease process is progressing, and so even if you have given the 5-alpha reductase, it is not a complete androgen blockade, it is just the partial, which is just preventing the conversion of testosterone into very active form, but still the testosterone is present, and so the progression of disease is going on, and most likely he will require the androgen deprivation therapy. Then I will counsel, you will tell the sir or the examiner that I would like to counsel the pros and cons for the surgical and pharmacological castration, so as to reduce the testosterone level, which will help to shrink the tumor, and hence there will be chance that the patient may be able to pass urine. At this time, I will also counsel that if I do the surgical castration, there will be fall in the serum testosterone to castrate level within 24 hours. So whatever catheter has been put, the tissue may shrink over a period of say 8. It is a trial and error, but we can try to give a catheter free trial or trial without catheter within 8 days, that is a 1 week time. We can still wait for few more weeks to see whether the patient can void, that is catheter free trial or trial without catheter. But if in spite of giving the adequate time where the castrate level has reached within 24 hours, but in spite of that, if the patient is not able to void, and since here patient is having acute painful retention, there is no possibility of patient having the myogenic failure, because myogenic failure is seen in the chronic obstruction where the patient is having prolonged duration of bladder outlet obstruction resulting into stretching, resulting into myogenic failure, where before subjecting any surgical intervention, patient requires urodynamic study. Since the patient is having acute painful retention, the possibility of myogenic failure is negligible. So you will tell the patient that if after surgical castration, if still the patient is not able to void, there is always a possibility that patient requires a what is called a channel TUR. The next question which will be asked to the candidate is, what is channel TUR? The channel TUR, it is a limited TUR done in the patient who is symptomatic because of the acute retention of urine, or patient who is having metastatic cancer prostate and so there is significant outlet obstruction. So here visual obstructing tissue, which you don't know, will be the cancerous as well as it will be the benign tissue, which is removed from bladder neck up to the veru midline part so as to create a wide channel. This wide channel will be wide enough to allow the patient to pass urine so that the patient will be catheter free, thereby improving the quality of the life. So here it is, you are not going to do any deep resection because you don't want to hunt to the capsule. It will be just to create a wide channel so that he is able to void with adequate flow, which is acceptable flow, so that the quality of life will be better. Rest of the discussion regarding the rest scenario of the cancer prostate we will discuss in next lecture. Thank you very much.